Well, I hope you all really enjoyed the breakout sessions that we've had here today. I heard a lot of great dialogue and interaction in the ones that I attended. I tried to get to them all, but somehow that wasn't possible. So really appreciate everybody engaging here today. We are going to kick off our final plenary here with the keynote comments, and we're going to hear from former Governor Kitzhaber, who's going to make some remarks, and then we'll take some questions. So, sir,
Good.
Go ahead.
I cannot believe you are still here at 3:30. Well, thanks for inviting me to join you this afternoon. I have not been able to go to the rest of the sessions, but my assumption is that you have spent a lot of time talking about workforce and the hospital discharge and capacity crisis, and hopefully a little bit about how our healthcare system is increasingly unsustainable from a financial standpoint. And of course, these daunting challenges are unfolding against the backdrop of a very polarized electorate and a very divisive election cycle. Those of you who were here a decade ago are probably thinking that this all feels really familiar. Or as Yogi Berra put it, it's like deja vu all over again. In 2011, those of you who were here, we were in the depths of the Great Recession, and we were facing not only a polarized electorate, but also a high unemployment and a very divided legislature, and a $3 billion revenue shortfall, about a third of which was in the Medicaid program. And that was the formula for political disaster in anybody's book. As it turned out, however, it was a triumph of good public policy over partisan politics, and I think there are some lessons from that 2011 session that we can apply today. So what we did is, instead of doing what most states did, dropping tens of thousands of people from the Medicaid program or slashing provider reimbursement rates, we looked instead at the delivery model and asked, how can we get more value for each dollar spent? And the result, of course, was our coordinated care organizations, which now provide quality, affordable care to over 1.4 million Oregonians and operate within a global budget that is indexed to a sustainable growth rate. You all know that story, but I think the aspect of the CCO story that's most relevant today is the handshake we struck with the federal government. In exchange for a commitment to reduce the Medicaid cost trend by 2 percentage points, CMS gave us a $1.9 billion 5-year investment to help us make the transition to this new delivery model. As a result, over the subsequent 5 years, we were able to enroll an additional 385,000 people under the ACA expansion and still realize a net total funds cumulative savings of about $1 billion. That outcome was due to a number of things. First and foremost, it was due to courageous leadership in the healthcare sector, the support of both business and labor, and it was also due to a willingness to subordinate parochial concerns in the larger interest of what was best for Oregonians. We are going to need that kind of solidarity and that kind of collaboration if we hope to today make that transition from where we are, this crisis point, to a more sustainable delivery model. So I'd like to use my time this afternoon to suggest one way we might go about doing that. And that starts with a recognition that there are two significant differences between 2012 and 2022. First, a decade ago, this crisis was focused almost entirely within the Medicaid program. Today, it's impacting the entire healthcare system. Secondly, if you recall, healthcare expenditures and healthcare employment continued to grow through the Great Recession. In other words, making margin was not part of the fiscal picture for hospitals during that period of time. That's not true today. This year, our hospitals saw a $103 million loss in operating revenues in the first quarter, another $111 million in the second quarter. This negative fiscal picture is compounded by the hospital discharge crisis. So I checked this morning, there were 435 people sitting in acute care hospital beds that needed to be discharged, but there's no place to send them. We also had 198 people being boarded in emergency rooms who need to get into an acute care hospital, and there's no beds for them. Now, that situation is due to a number of factors. Part of it is structural problems and misaligned incentives between hospitals and insurers, between our acute care system and our post-acute system. But the primary driver of this crisis is a pre-existing workforce shortage in the healthcare sector that was exacerbated by the pandemic, where this tremendous stress that was brought to bear on nurses and other frontline workers, including first responders, I might add, led to burnout and forced hospitals to hire very expensive contract labor to backfill those who had retired or those who chose to leave for a less stressful job. So this convergence of factors is becoming increasingly lethal. Oregonians are dying. Oregonians will continue to die and suffer avoidable harm because of this hospital discharge situation and the workforce staffing crisis. We have people in rural parts of our state who need a higher level of care and can't be transferred because there aren't any beds available. Ambulances are being diverted. And those who are being boarded in the ER are being cared for by an overburdened staff that are also responsible to address the medical and surgical emergencies that come through the door at any time, day or night. So as you've probably heard today, our hospitals are facing really a perfect storm. They're looking at falling revenue and escalating operating costs. That revenue loss is due in part to the fact that they can't discharge people who no longer need to be hospitalized. Some of it is due to the fact that they're now paying back the federal loans that helped shore them up during the recession. And at the same time, inflation has increased the cost of supplies and equipment. But the fact is, it's the cost of labor that's by far the largest driver of hospital operating costs, both because of the use of high-cost staffing agencies, but also funding collective bargaining agreements for existing workers. So the sobering fact that I think we need to come to terms with is that the cost structure of our hospitals, and I would argue of our larger healthcare system, is increasingly unsustainable from a fiscal standpoint. You know, we've known this moment was coming for a long time. This should not come as a surprise to any of us. We've just lacked the political will to face that reality. And I think we've been aided in our denial by debt financing at the federal level and from these infusions of public dollars that have sort of made the surface seem a lot more placid than it really is. This reminds me of that passage from Hemingway's novel, A Sun Also Rises, where Bill Gorton is asking Mike Campbell how he went bankrupt. And he says, well, it happened two ways, gradually, then suddenly. That's pretty much where we are. Now, if this wasn't enough, the stress on the system is being compounded by Oregon's Healthcare Cost Growth Target Program. Now, if you recall, this was created in 2019 under Senate Bill 889, and it created a healthcare cost growth target across all markets of 3.4% for the years 2021 through 2025, and then down to 3% for the following 5 years. And in order to reach this 3.4% goal, virtually every provider and payer organization in Oregon signed a voluntary compact in which they agreed to achieve a set of targets that would increase the use of advanced value-based payment models over the next 5 years. There we go. And there's what's in that compact. Payer and provider organizations that fail to meet this in any given year could be subject to a performance improvement plan. And if they fail to meet those targets in 3 out of 5 years, they can be subject to financial penalties. Now, in fairness, this compact was signed last year, before this crisis had really matured. But it's clear that given the fiscal pressures on the system that we just discussed and a national inflation rate of around 8%, that these targets, for all practical purposes, are unattainable, exposing both payers and providers to the possibility of performance improvement plans and to fiscal penalties. Now, that's a lot to have to deal with at the same time. But in fact, it is the landscape before us as we approach the 2023 legislative session. We are entering really uncharted territory that is fraught with risk, no doubt about it. But it is also filled with opportunity, because the only way we can navigate that territory is if we do it in partnership with one another. And that journey has to begin by recognizing that the crisis we're facing today is not cyclical, as in the economy, and it's not situational, as in the pandemic. It is structural. And it's not going to go away by just dealing with workforce. We have to also deal with the underlying cost structure of the system to ensure that it reduces the total cost of care over time. So it seems to me the only question is whether we have the courage and the wisdom to do what it's going to take, because it's not going to be easy. Right now, payers and providers, labor, long-term care, and the post-acute sector have retreated to their respective bunkers, ignoring the fact that ultimately they are all in the same larger system and their fates are ultimately linked. Maintaining this posture, I think, is like all of you being in the same canoe drifting towards the lip of a waterfall. And your response is, no matter where you're sitting, you're taking your paddle, your stakeholder paddle, and you're trying to keep your end upstream in the belief that just because you're on the front end of the canoe, you're not going to go over the fall. We can do better than that. We can do better, and we have to do better, because the ultimate victims, the ultimate losers of this posture and this scenario is the very people we are supposed to serve. The Oregonians who need access to quality, affordable health care. So the question that's staring us in the face is simply this: are we going to lead or react? Are we going to be architects of the future, or are we going to be its victims? We have a choice. We get to make this choice. I'm here today because I know we can make the right choice. I'm here because I believe in you, because I believe in us, and because I believe that in the midst of this toxic, polarized environment, all of us ultimately yearn for a renewed sense of community. We yearn for some sense of shared identity as Oregonians, and we yearn for a path forward that's built on collaboration rather than conflict. A decade ago, it was our commitment to put what was right for Oregon first that led the bill that created our CCOs to pass by overwhelming bipartisan margins, 57-1 in the House and 22-7 in the Senate. When have you ever seen a piece of healthcare legislation enjoy that kind of margin, that kind of majority in Congress, or I would argue in any other state? And I remind you of that simply so you don't forget what we're capable of. We've done this before and we can do it again, but we can only do it together and only by holistically addressing both components of the crisis. So I think it's imperative that we put aside our past animosities and come together as we did a decade ago to address not only the immediate crisis, but also the interconnected need to develop a path forward that restructures and stabilizes the delivery system. Now, there's a lot of moving parts, obviously, but I want to focus on just two that I think are ultimately the most important for our long-term success. Workforce, which I'm sure you've talked about a lot today, and then realigning the incentives in the delivery system to reduce the total cost of care. And let me also reiterate that these two challenges are closely related. They cannot be solved in isolation from one another. So let's start with workforce. As we discussed earlier, the cost of labor is the major driver in hospital operating budgets. In most hospitals here in Oregon, it's 55, 56%. At an academic institution like OHSU, it may be north of 65%. And that brings us to the rub, right? How can we reduce the hospital cost structure and to keep these institutions solvent so that we can maintain these services for Oregonians when almost 60% of the cost is in labor? That is the conundrum we've got to address, and there's no way to avoid it. But how we answer that question is a central part of our challenge, and I believe we can't answer that question except in the context of what we have expected of that workforce over the past 2 years. And if I were to describe our healthcare workforce today, I would use the term battered. In the depth of the pandemic, month after month, surge after surge, these workers shouldered the stress and the human tragedy of COVID-19. They risked their lives, they worked days and weeks at a time, often with inadequate protective equipment or oxygen or other important supplies. And I'm not just referring to our nurses and doctors and respiratory therapists and those who are involved in direct patient care. I'm talking about the housekeepers and the janitors and the food service workers who also risked their lives to keep these institutions open during those very dark days in the depths of the pandemic. In my view, these people deserve to be paid, and they deserve to be paid well. In fact, I don't think anyone should work for a hospital or for any other part of the healthcare system in Oregon and be paid so little that they qualify for the Oregon Health Plan. Now, one of the ways that we can ensure a good pay is through labor unions and collective bargaining agreements, both of which I have supported for many years and continue to support. But the unavoidable fact is we have a math problem, and it's a math problem that affects all of us. The math problem is that the cost structure of the hospitals is unsustainable, and nearly 6% of that cost is in labor. So right now we're in crisis, right? And the relationship between hospitals and labor is largely confrontational. The reality, however, is that today anything that increases the cost of operating a hospital is going to impact patient care by reducing access or undermining quality. So mandatory minimum staffing ratios is a case in point. Staffing ratios are really important, and I've always supported them. If the patient-to-nurse ratio is too high, it undermines quality, it compromises patient safety, and it leads to burnout. But if a hospital is unable to meet the ratios because they simply can't hire enough nurses to fill the open slots, then their choices are limited. One choice is to hire more contract labor, but that widens the gap between operating revenue and expenses. Another choice is to close some beds to meet those ratios, but that compromises access by reducing capacity. So the point is that both these choices actually exacerbate the existing crisis and ultimately don't serve the best interest of hospitals or labor or the Oregonians who need access to care. The Chinese general Sun Tzu in The Art of War wrote that he wins who knows when to fight and when not to fight. And there's wisdom there that we need to think about today. The enemy here is not better pay for our healthcare workforce, and the enemy is not hospitals that are struggling in a business model that is no longer sustainable. The enemy is that payers and providers and labor continue to operate in silos when the only path forward requires a coordinated approach. That's the problem. That's the enemy. Now, addressing this problem, first and foremost, needs the creation of some kind of safe forum. I would call it a safe forum, a framework that engages all of the relevant players, that provides a larger common context for the challenge we're trying to address, and makes explicit the consequences of how different individual choices and strategies by all of these players play out over time, and creates a space, a network, a framework where there is shared responsibility and accountability for developing a path forward. The North Star for that framework, for that safe forum, the policy outcome that needs to guide all of the individual strategies and decisions is very simple. The ability to provide timely, affordable health care for all Oregonians in a system that is equitable and fiscally sustainable. I'm not suggesting that we pay our healthcare workforce less. I'm not suggesting that we don't take a serious look at mandatory minimum staffing ratios. What I'm saying is that those conversations cannot take place in a vacuum because they are interrelated. We need a place where labor and payers and providers, the long-term care sector, can come together and work out a collaborative way that works for all of us to address both the immediate crisis of workforce access and capacity, as well as the need to change the underlying cost structure of our delivery model to reduce the total cost of care. I think that creating this space, this safe forum, is the single most important step we can take to begin to unbundle the crisis that's swirling around us. I think creating this safe forum should be one of the top priorities of our next governor and our legislative leadership. And we cannot wait till next year to begin this conversation. It needs to begin as soon as possible. It should have begun months ago because we have seen this coming. This should not be a surprise. So once we've created this safe forum, what does the path forward look like? Well, solving the workforce shortage and changing the cost structure of our delivery system cannot be done in isolation. It requires an interconnected strategy that needs to be concurrent and converging. So the first part of the strategy involves focused investments over several biennia to increase the capacity in our system of post-secondary education to train more healthcare educators and to train more healthcare workers. And I'm not just talking about nurses, although they are very, very critical. I'm talking about community mental health workers and peer support specialists and childcare workers and those who provide home health services to an aging population. And if we want a solution, this workforce has to be well-paid, and professional and stable so we can expand our capacity to care for people in home and in the community and not just in our acute care healthcare system. At the same time, as you know, we have this immediate workforce challenge, and I think that requires an emergency 24 to 36-month effort to significantly increase the number of CAs, CNAs, and LPNs and RNs that are graduating from our universities and colleges and our training programs. And that emergency strategy needs to be intentionally linked to an effort that will dramatically increase the number of advanced degree nurses and nurse practitioners in Oregon to help counterbalance what we expect in the future, which is a decline in the number of primary care physicians in our state. Now, the success of designing and implementing that strategy and these interconnected efforts is going to require political leadership, it's going to require leadership in the healthcare sector, and it's going to require trust, and collaboration and innovation between payers, providers, labor, and the Oregon State Board of Nursing. Now, paying for these investments is another matter, and that's where we have the intersection between the workforce strategy and our strategy to redesign the delivery model. As we discussed earlier, our current healthcare cost growth targets are unattainable. That makes payers and providers pretty nervous. And there will be pieces of legislation introduced next year to try to address that. One in particular that I've seen would exempt payers and providers from either a performance improvement plan or from fiscal penalties if their cost above the growth target is driven by, and I think here's the exact language, costs incurred to meet the community's need to access health care. Now think about that for a minute. I understand why these pieces of legislation are coming forward, but if passed in that form, this would essentially and effectively eliminate Oregon's cost growth target program without offering any other way to address the cost in the system. Apparently, on the assumption that the public sector is going to continue to support what is increasingly an unsustainable business model. It should be clear to all of us from the federal resources that have propped up the system for the last 2 years and from the E-Board appropriation last month of $40 million to sort of prop up the system, the workforce system we have today, that this healthcare model is no longer sustainable without the ongoing investment of public dollars. But given the other constraints and demand on public resources and public budgets, not to mention a national debt that is now over $30 trillion, believing that the legislature or the U.S. Congress is going to continue to have the resources to subsidize this system as it looks today is magical thinking. Magical thinking. Clearly, we need to modify the unrealistic targets and timeframes in Senate Bill 889, but there has to be another side to the handshake, or there is no credibility. There has to be another side to the handshake. And the only way, in my view, that additional public resources are going to be appropriated on an ongoing basis for this system is if it is used to truly fund a transition from the system we have today to one that is economically sustainable. That's going to involve, among other things, a shift from fee-for-service to some kind of prospective payment model in a global budget that's indexed to some kind of sustainable growth rate. Indeed, the Senate Bill 889 Commission expressly directed the Oregon Health Authority to help move this market to value-based contracts in which payers and providers equitably share in the upside and downside risk of the total cost of care in a global medical budget. So how do we get there? Implementing the CCO model, as I mentioned earlier, 10 years ago, I think offers us an example of how we could make this transition. Remember that it was Oregon's commitment to reduce the Medicaid trend line 2 percentage points below medical inflation that allowed us to pay back that $1.9 billion investment and still realize a cumulative savings of over $1 billion. It's this delta of savings that accrues from reducing the trend that creates the opportunity that we took advantage of 10 years ago. In this case today, we would structure an initial federal investment to help address the workforce and labor issues that are driving much of the current fiscal crisis facing us today, with that investment being paid back over time by reducing the overall total cost of care. And in a framework in which labor and providers and payers share in the responsibility and the accountability for finding a path forward, we could stage and phase in both the immediate need to stabilize the workforce and fund collective bargaining agreements and the long-term investments that are necessary to increase the size of the healthcare workforce over the long term. But time is not our friend here. Time is not our friend. The $40 million that are helping hold the workforce together ends in 6 months. If we don't act soon, if we don't act very soon to create a framework to resolve the long-term cost structure and problems in the healthcare system, this issue is going to explode in the middle of the 2023 session, right when the legislature is struggling with a whole host of other issues, from crisis in our behavioral health system to houselessness and chronic housing underproduction to the mental health impact that the pandemic has had on our kids and on their teachers and on their parents, and quite possibly in the middle of a recession. Let me just close by saying that, we can do this. We can do this. We have done it before. We are limited only by our own imagination and by the depth of our commitment to one another, and by our willingness to let go of a cost structure that simply is not working for us anymore. It is no longer a life vest. It has become an anchor. None of these issues that we talked about this afternoon are Republican issues. None of them are Democratic issues. There is no partisan solution to any of them. There are only solutions that recognize and embrace the fact that we are all in this together. In this divided state of ours, and in our divided communities, we should never forget that we have a choice. We have a choice whether to react or lead. We have a choice whether to design the future or be its victims. And we should remember that partisanship is a choice, and so is civility. We have a choice. We have a choice about what we want Oregon to be. We have a choice about what we want to be as Oregonians and as fellow human beings. And I think it's a choice to put understanding before reaction, to put collaboration before conflict, and to put reconciliation before recrimination. And what we're going to need next month more than anything else in this state is reconciliation. We can't solve this without reconciliation. And to me, reconciliation starts with each of us. It begins in the heart of each individual, animated by a choice and a decision to make our community better, to re-knit the fabric of our society and of this great place we call Oregon. Let's do this. Thank you.
Thank you very much. Thank you so much for those comments. And, it was wonderful to hear your perspective, taking that then and now approach and really moving. I think one of the things that I thought about as you were talking is we started our day today with the health system speaking about the challenges that you outlined as well. But also the word partnership came up over and over again in those conversations, and not doing it alone. And I think you've expressed that again here today in a great capstone to the conversation. We have a few minutes to take questions for the governor if there are questions or comments from the audience.
They want out.
Any comments, questions? I know it's a little hard to see. You need a visor.
Hard to see.
We have a hand up front.
Thank you, Governor, for your comments. I think you've outlined things pretty well, but I have some questions in my mind. On Tuesday, I will be retiring from state service, but I have been part of the labor movement and part of the unions, and I am really tired of seeing women in particular, but it crosses all genders, descriptions, of coming down with PTSD because of workplace bullying that is being condoned and not condemned by state agencies, and I am including it right up to the present governor, and I can bring her own emails to the workforce saying it's not to be tolerated. So how do we deal with that? I'm going to be a taxpayer for the rest of my life, and I do not want my tax dollars used to do this. And I do want to reference Senate Bill 1586 that goes into effect January 1st of 2023. And those are changes, but they have to be enforced. We've talked a lot today about accountability. And yes, it does have impact on the health systems because people need treatment. Thank you.
Yeah, so I think that in an effort to make lemonade out of lemons, I think there's a unique opportunity here to redefine the relationship between labor and management. The workplace has to be a place where people feel safe, where people feel that they are valued and are adding value. It's not just about take-home pay, although that's a part of it, but it's a larger issue, which I think you pointed out. And if we can get everybody out of their bunkers and in the same place where we are all trying to achieve a much more professional, well-paid, and stable community-based workforce, as well as a hospital-based workforce, that's the gold standard. I mean, one of the reasons we have trouble in our mental health system is because we don't have a stable workforce at the ground level. And so I think what the workforce environment is definitely a part of this conversation. And I appreciate you bringing that up. I want to just make one more quick comment so I can get it in, because I think this is really important. Making a transition, it's all about how you fund the transition. It's all about how you get from a place you are right now, which is safe, at least it seems safe. You're still heading for the waterfall, but it seems safe. You're not in the water. And to some place that is still undefined, right? I'm a great believer in not accepting the world as it has been constructed. We built this system and we can change this system. And in 2012, this was a Medicaid problem. And we got a significant investment of resources that in the end lowered the cost of Medicaid to the federal government, right? This is what we have today is impacting the entire system, not just the subsidies that the federal government is paying for Medicaid and Medicare, but also the tax expenditure for employer-sponsored coverage and the subsidies that are in the ASA individual market. There is a huge opportunity here. If we could figure out a way to bend down over time the cost growth, and I'm not talking about 3.4%, I'm talking about something a couple percentage lower than medical inflation, you could construct a scenario where we could in fact get a federal investment. We've got our senator, senior senator, as chair of Senate Finance, to actually help us fund this transition, the crisis in our immediate workforce, but also the long-term workforce and the changes that have to be made within the system. But if we aren't willing to step up and say, we can do this, then we are going to continue to be victims. And I just think we are so much better than what's going on in Oregon right now.
Richard Gibson, Comagine Health. I love you going back to 2012. I'd like you to go back to 1992. And if we're going to have a sustainable model that both the healthcare organizations and the employees can get along with, don't at some point we need to decide that some therapies aren't worth the cost? Meaning that, as you did in 1992, we ranked the diagnosis treatment pairs, but not to be so literal about it, but in general to say, here's the amount of money we're going to spend on healthcare in 2026, but some things aren't worth it because they don't yield enough value in their, because they're too expensive for the value they deliver. But isn't that a place where instead of having a profit motive continually to push more and more treatments that are more expensive, but perhaps in some cases diminishing returns, is there a place for a conversation about some things just aren't worth it, and that's how we make up for it so that we can afford the future, but not make it so that access is unattainable?
So you've tossed me a can of worms with 4 minutes and 30 seconds left. I'll take a cut at it because I think this is first of all, I wouldn't use the term "isn't worth it." If it's an individual, it's worth it to that individual, right? Here's the conundrum: you can practice medicine one individual at a time. It's really hard to develop a social policy one individual at a time. You're trying to take the public resources you have and get the greatest benefit, which is really why we did the prioritized list. I'm going to come back to that because there's some problems with it. The idea was to create a space that was separate from the political process to basically prioritize the service, health services based on the health impact for the entire population being served, right? And then the legislature would fund that list, which is a political decision. So they would be accountable for what we put in the benefit, but also for what we left out of the benefit, right? It never told the provider they couldn't provide the service, but we used that to build our capitation rate, right? And I think we're still the only place in the country that has that tool, which I think will be increasingly important as we go forward. At the same time, we know a lot more now than we did in 1992. We know that the evidence behind a lot of treatments has been garnered from a fairly narrow segment of the population. It does not have the diversity that it needs to understand how various treatments affect communities of color, for example. So we need to have that conversation. So it's not just taking what we have, it's updating it, it's addressing some of these legitimate concerns about equity that are very valid. But we shouldn't throw the whole thing out, because it does provide that framework for having that conversation. And what most states do right now is they make those decisions in a vacuum, in a black box. It's not public, it's not open. And what happens, when you don't spend money on one, or you spend a lot of money on one service, something else drops out. I'll just give you an example. I was talking to someone before. The impact on an individual of not getting an organ transplant is right in your face. The impact of a child who is allowed to live in a family where the mother's on methamphetamine and the father's in prison and they have food insecurity every day is just as deadly. And I would argue costs society a whole lot more over time. So we just need a place to have those conversations about limited resources where we can reason with one another and find a path forward that allows us to spend our resources in the best possible way to make Oregonians as healthy as possible.
Thank you. Oh, got one more?
One more. I'll make it quick.
No
Governor Kitzhaber, thank you for coming. Laura McKean, I'm the Director of Oral Health Services for All Care. And 2 comments. I haven't heard, we've talked a lot about workforce today. I haven't heard a lot on my end about alternative workforce models. And I just want to throw out there dental therapy. We finally got the bill passed for dental therapists to be licensed. It's a great alternative workforce model in the dental field. And second, the loan repayment program, I chair the Healthcare Workforce Committee for OHA. Currently, the loan repayment program will not cover someone if it has an AA. You have to have a bachelor's. So we're working to try and get that changed, because I know a lot of nurses that have an AA that would love to take part in that program. So I would encourage everyone here attend the Healthcare Workforce Committee meetings if you can. And thirdly, really quick, thank you for supporting oral health. I appreciate it.
You're welcome, and that's a great point to end on. I do think we have to be very creative here, because people are falling through the cracks left and right, and this workforce problem has been coming at us for a long time, and this crisis, as they say, is an opportunity, and we have an opportunity to rethink, be incredibly innovative on how we expand that workforce in a way that works not only for the workforce, but for the people they serve. And we have a history of doing this in Oregon, of working across party lines, but across sector lines. And if there was ever a time to do it, it's right now.
Well, that is the very definition of state of reform and a definition of our conversations here today. Really appreciate all of you taking your time. Thank you, Governor, for your comments. Thank you to our sponsors for this wonderful opportunity to come together. And please join us and continue to come together out at the reception in the pavilion. Thank you so much, and thank you, Governor. Really appreciate it.
Thank you very much.